Good morning. Good morning. This is an audio, video, and sharing check. Can you hear me? Can you see me?
Yes, sir.
Yes, sir.
Can you see the slide which I have presented?
Yes, sir.
Yes, sir.
Good, nice. And could you see the chat which I had initiated?
Yes, sir.
Conversation. So could you get a time to go over to the video which I had uploaded on that Teams? Could you see that video?
Yes, sir.
Okay, good. It's very important that all of you should see that video. It just takes about 55 seconds or so. But once you see that, it will help you in understanding what we are going to discuss today. So someone, if have not yet seen that video, I'll recommend you have a look at that video while we start the class here. So we'll give you 1 more minute time. Please check that video so that we all are on the same grid. Nice to see that majority of you have joined the class, but I think even now some people are still not in time. I guess I'll have to now check as to what time you log in and what time you log off and give the attendance accordingly. So people who join in late may not get their attendance. Okay, I think everybody should have seen the video. So we will move forward to our today's class. So here is a picture. Have a look at this particular photograph. And what do you make out by looking at this particular child? There is one child, very happy, healthy looking child on one side, and then the big part of the screen is covered with a child which is not really looking healthy. What do you think? What do you observe in this particular child? One, you can see the distress in the eyes of the child. Two, you can see his alanasi, the nasal folds are blown, are wide apart. This is an indication that the child is finding difficulty in breathing. Third, his mouth is open, that means he is also trying to breathe through the mouth. Fourth, his tongue is protruding out. This shows air hunger. Look at the neck of the child. Look at the arms of the child. Look at the chest. You can see the intercostal muscles getting contracted and pulling in. You can look under the chest, the two dimples on either side in the hypochondriac region, left and right hypochondriac region. You can see depressions over there. You can look at the abdomen and then go look at the thighs. Look at the strain which is there. All these are the evidence of the difficulty which the child is feeling in inspiration. He's trying to inspire, he's trying to take a deep breath or even a shallow breath, but he is not able to do that. It's the most distressing condition. When you can't breathe in and when all your system wants oxygen, but it's not getting because your respiratory tract is not able to inhale as much air as it should, is the most distressing situation in life. And we are going to see something like that. If you have seen the video, you would have perhaps understood the severity of this condition. So we are going to talk about a very, very important infection, Bordetella pertussis, a disease which has killed thousands and thousands of children, which even now kills a large number of children in developing countries, but which can be prevented. It's more deadly than COVID. So we are these days taking lots of precautions to protect ourselves from COVID. We're spending billions of dollars in prevention and treatment of COVID, but Bordetella pertussis poses a greater danger to the children. So in this particular two classes, we are going to see the microbiological aspects of Bordetella pertussis as the bacteria. We are going to look at the disease which is caused by Bordetella pertussis, also called as whooping cough or pertussis, its clinical features, its profile, its pathogenesis, its complications. In the next two classes, we'll see what are the vaccines which are available for prevention of this disease, what are the advantages, disadvantages of each type of vaccine, and how we can best utilize these vaccines and other prophylactic measures to prevent this disease amongst children. And then, despite vaccine, we still have some problems with pertussis. And we have not yet been able to eliminate this disease. We still have children who suffer from this disease. And what can we do to tackle this current problem of pertussis? So first two things we'll talk in today's lecture. The other two things we'll discuss tomorrow. Just the basics of the bacteria. Now, I'll recommend that this particular lecture is only going to give you important points related to Bordetella pertussis. You need to understand this organism and the disease in greater detail. So it's mandatory that you all must consult your books, read the chapter thoroughly, carefully in your books, as well as from other sources. So let's talk about the organism. It's an aerobic gram-negative bacteria which has got much smaller size as compared to other bacilli, and therefore it is called Coccobacillus. Roundish and short and stubby in gram stain. It can be present in singles. It can be present in pairs. Since they are very small, sometimes they can be confused with gram-negative cocci. Therefore, when you are doing a microscopic examination, you need to look carefully at the shape and the size of the organism and its arrangement to say it is Coccobacillus and not gram-negative cocci. It's a fastidious and slow-growing organism, and being fastidious, it requires blood and nicotinamide for its growth. Therefore, it will not grow on print agar, it will not grow on McConkey's agar, but it will require blood agar or chocolate agar to grow on. And on blood agar, the colonies are hemolytic in nature. Since this bacteria is present in the respiratory tract, and there are a large number of other bacteria which could be commensals in the respiratory tract, therefore we need to have specialized medium which could be selective medium for isolation of these bacteria. One such medium is Bordet gangue agar. We'll talk about this agar a little later, but just remember that it requires blood containing media, and since it is a slow growing organism, other commensals may overgrow in ordinary blood agar. Therefore, we need to have a selective medium excuse me, for isolation of this particular bacteria. It's a catalase positive organism and it does not ferment any sugars or any carbohydrates, and therefore it is called a non-fermenter. So you don't have to worry about remembering its fermentation reactions. Just few things to remember. Hemolytic on blood agar requires specialized media and is catalase positive. So this is how Bordetella pertussis looks like. Small gram-negative cocobacilli may be arranged in pairs, may be arranged in singles. This organism is not present in the environment. It is present only in the respiratory tracts of human beings. So we cannot get this infection from the environment. We have to be in contact, or we have to get this infection from someone who is harboring and carrying these organisms in the respiratory tract. And in the respiratory tract, this bacteria gets attached to the respiratory epithelium, particularly to the cilia of the respiratory epithelium. I hope you have been taught about the histology of the respiratory tract and which particular part of the respiratory tract has got ciliated epithelium. Just recall that locations, and this is where the bacteria will get attached to. The bacteria can invade the alveolar macrophages. It can remain alive in the macrophages. It resists phagocytosis. It resists intracellular killing, and therefore can survive in macrophages for quite some time. And that's from where it comes out and infects another person. So it's a specific to human beings. We do not get it from animals. We do not get it from cold air. We do not get it by drinking cold water or having ice cream or environmental pollution. No, none of them are important. It's only human to human contact which spreads this infection. And that's very important, because if we can prevent human to human spread, we can eliminate this particular dreaded disease. Once we put it onto the culture medium, but before putting it on culture medium, we need to collect a specimen, and that specimen collection could be by a swab or could be by the cuff, not sputum. Interestingly, the patients with Bordetella pertussis do not bring out much sputum. So sputum is not the specimen. Usually it's a cuff plate. We'll talk about cuff plate later on. But this organism is fastidious as well as sensitive to fatty acids, to metal ions, to sulfides, to peroxides. So anything which contains any of these components, any of these chemicals, can destroy the bacteria and may not allow it to grow. This is especially seen when we try to collect the throat swab with a cotton swab. The cotton fibers have got fatty acids, and when we sterilize the cotton swab by hot air oven, these fatty acids are released and they can inhibit the bacteria, and therefore cotton swabs are not ideal for collecting the specimen. The bordered gingiva medium or BG medium contains potato starch as the base, which helps in selective growth of these bacteria. Similarly, there is another culture medium, Regan-Lovey charcoal medium. This contains charcoal, and the charcoal neutralizes the fatty acids and allows the bacteria to grow. This medium also peptose horse or sheep blood. So the two important media for isolation is BG medium and Regan-Lovey charcoal medium for Bordetella pertussis. It's extremely contagious disease, extremely contagious, much more contagious than COVID. And therefore, before COVID times, whenever there used to be outbreaks of whooping cough in a particular locality, there used to be signs posted out that this locality has got whooping cough, keep out. Do not enter this area, do not enter this house, do not come in contact with the people. As we had discussed earlier, the bacteria get attached to the epithelial cilia, and that is what is most important for its pathogenicity. So the bacteria are attached to the cilia of the epithelial cells. When the person coughs or sneezes or breathes out, these bacteria may get dislodged from the cilia, may come out in the respiratory air and or to the other people who are nearby where they can get infected. This is a better picture which shows these are the bacterial cells and these are the epithelial cilia, and you can see a cluster of bacilli attaching to large number of epithelial cells cilia, and over a period of time they destroy the cilia and then the epithelium becomes non-ciliated. Once it becomes non-ciliated, it allows the other organisms and the bacteria to go further down into the respiratory tract. The main purpose of cilia is to capture foreign particles, including bacteria, and throw them out. And the bacteria effectively neutralizes this particular defense mechanism of the cells. So to do that, what the bacteria requires it must get attached to the epithelial cells, to the cilia. It must evade the host defenses like the phagocytosis, and to help the bacteria do these two things, the bacteria produces a large number of endotoxins and exotoxin, which will enhance the pathogenicity of this bacteria. So let's have a look as to how the bacteria causes disease. What is the virulence factors? Important features: adherence, production of the toxins, and evasion of the defense mechanism. So this is the long list of toxins which are produced by the bacteria. Pertusis toxin, filamentous hemagglutinin, pertactin. The fimbriae also play part in virulence. There is adenylate cyclase toxin. There is another heat-labeled toxin. There are lipopolysaccharides which come from the bacteria because it's a gram-negative bacillus. There is tracheal cytotoxin, and you need to know about all these toxins. These various toxins perform various roles in virulence. The second part of the slide which you see are the virulence factors and what particular mechanism is affected by which particular. So like attachment to the respiratory epithelium is facilitated by pertussis toxin, by filamentous hemagglutinin, by pertactin, by fimbria. Similarly, histamine release is facilitated by pertussis toxin. Phagocytosis is also inhibited by pertussis toxin. So this is the whole list of the toxins and the list of the virulence mechanisms. You need to remember this because this is a very common question to ask. What are the virulence factors? What is the virulence and how is the pathogenesis of Bordetella pertussis influenced by these various virulence factors? So the cell epithelium gets attached, or the bacteria get attached to the epithelium. They produce histamine release with the help of pertussis toxin. They inhibit phagocytosis and allow the bacteria to survive. They also force the human body to produce interleukin 4 and immunoglobulins E, which is stimulated by pertussis toxin. There is a cytotoxic cytopathic effect by pertussis toxin and tracheal cytotoxin. There is agglutination of the blood cells by fimbrial hemagglutinins. There is apoptosis of the cells, again caused by adenylate cyclase toxin. Hemolysis also by adenylate cyclase toxin. There is interleukin 2 production. There is production of nitric oxide synthetase, and all these factors contribute to the manifestation of pertussis as a disease. Depending on which virulence factor is more or less effective, The clinical features of pertussis may vary in its extent or in its expanse. So we can see some people who are more affected, we can see some people which are less affected depending upon what type of toxins are being produced and what they are doing. Here is the artist's view of the bacteria. This is the gram-negative Coccobacillus. These are the fimbria. These are the filamentous hemagglutinins. These are the various toxins which are produced from it. There is a pertussis toxin which is excreted by the bacteria into the environment. So it can go to the far off places also and cause damage. And this is what is the enemy which is going to cause problem. Consider this as an epithelial cell of the respiratory tract and these strong long spikes as the cilia. The cilia move left, right, or up, down, and they force the secretions or foreign material out of the respiratory tract. So cilia play a very important defense role. What the bacteria does is, one bacteria by its filamentous agglutinin or by pertussis toxin or various other fimbria, it gets attached to adjoining cilia. If it is attached only to one cilium, it doesn't matter. That cilia can throw it out. But when it gets attached to the cilia on either side, it effectively inhibits the movement of the cilia. So the main action of all these attachment is cilia protective function is neutralized. So that's the first step in pathogenesis. Once the bacteria is attached over there, it starts producing various toxins and various chemicals, etc., which are secreted out, which may have local effect or which may have systemic effect. If these toxins get into the system, particularly the pertussis toxin, adenoid cyclic toxin, or tracheal cytotoxin, dermonecrotic toxin, all these toxins act on the mucosal surface and destroy the mucosal lining. Once the mucosal cells are destroyed, those cells are thrown out. They get detached from the lining of the trachea, lining of the bronchi, lining of the bronchioles, and they are dropped into the space. They are dropped into the cavity, and that is where the paroxysmal cough starts from. We'll come to that a little later. All these things help into attachment to the cilia, and from there the organism may the macrophages, and once inside the macrophages, it doesn't get killed by the macrophage, so it can survive for long duration, multiply over there, break the macrophage, and go out and invade other epithelial cells. So persistence and transmission is dependent on its ability to evade phagocytosis, grow inside the macrophage, and be thrown out from the body along with the cough to spread into the environment and to other persons. During all this stage, our immune system is not sitting idle. It tries to control the innate immune system as well as adaptive immune system, and those effector cells will control the control the entry into the macrophage as well as try to neutralize various toxins, try to neutralize the bacteria as a whole, try to kill the bacteria as a whole, and will control the infection. Now, the clinical manifestation depends on how the balance between these two is struck. If there is balance more in favor of the effects of the toxins, there will be clinical feature. When the immune system starts taking over, there will be a recovery from the disease. Now let's have a look at each of these toxins. The pertussis toxin, the adenylate cyclase toxin, the tracheal cytotoxin, the lethal toxin or dermonecrotic toxin, It's called dermonecrotic because this toxin is found to destroy the cells of the skin, but we really do not know what role it plays in the respiratory tract. Perhaps it kills the cells of the respiratory tract also in the same way as it kills the skin epithelium and the heat labile toxins. So these are the various toxins. Let's have a look at Pertusis toxin. It's important for colonizing. It's an endotoxin. It's cell bound, but it can also get secreted extracellularly also. Now that is uniqueness. Most of the endotoxins do not get secreted extracellular. They remain, and once the cell destroys, then they become effective. But Pertusis toxin is unique in that it is cell bound as well as extracellular also. By being extracellular, it influences the phagocytosis and prevents the phagocytic cells from being effective. This toxin goes into the circulation through the lymphoids, goes into the lymphatic, goes to the lymph node, and in the lymph node it leads to hyperplasia of the lymphoid system. That's a good thing. You might think that because of lymphoid hyperplasia, there will be more adaptive immunity and therefore we should be able to control the infection. Yes, the body tries it in that fashion, but it doesn't always work in that fashion. So here is a diagram which shows different subunit components of the Pertusis toxin. You need not remember this whole diagram. Just remember that it causes lymphoid hyperplasia, it's got antiphagocytic effect, and it could be intracellular as well as extracellular. The effect of lymphoid hyperplasia is that if you study the respiratory tract, you will see that it is studded with lymph nodules. All along the respiratory tract, there are lymph nodes. These lymph nodes play the role in monitoring the entry and exit of the organisms in the respiratory tract. So they are very close to the trachea, bronchus, bronchi, bronchioles, etc. There is lymph nodes and there is other lymphoid tissue also. Now, when the hyperplasia of these lymph nodes or lymphoid tissue occurs, it presses onto the respiratory tract. So if this is the tubule, maybe respiratory bronchus, bronchiole, bronchi, whatever it is, if there is lymphoid tissue over here, if lymphoid tissue overgrows, it may compress and narrow down the aperture of the respiratory tract. That is one important pathogenesis of lymphoid hyperplasia leading to presentation as pertussis. This is a protein in structure, and as we discussed last time with diphtheria, it has got A and B, two components. As we discussed last time, the B component is responsible for attachment or binding to the cells, and it is the A component which is actually the active component, which when gets intracellular causes all the problems. So remember, Pertussis toxin having component A, component B, B for binding, A for action. And in that action, it attacks ADP ribosyl transferase. Now, how it does is, let's see. The A subunit is released into the cytoplasm of the cell. The ultimate effect of this A subunit is that it disrupts the cellular function, it decreases phagocytosis, and it acts as a chemotaxis and attracts more phagocytes towards it. So it actually attracts phagocytes and it destroys phagocytes. All this leads to edema in the tissue. All this leads to congestion. All this leads to decreasing the or narrowing the aperture or the diameter of the respiratory tract. How it does is that this is the biochemical mechanism by which it does. As we explained, it goes to attacks the ADP, NAD, and mainly is the protein, the regulatory protein GI. I think biochemists must have taught to you about the activity of the regulatory protein GI that inhibits the eukaryotic adenylyl cyclase. And this inhibition is what leads to accumulation of CMP, and this accumulated CMP is the one which leads to all these changes in the function of the cell, causing phagocytosis as well as causing chemotaxis. Now these are the local effects, but as we have seen, pertussis toxin is excreted out of the cell also, and therefore it gets absorbed and it goes into the lymphoid tissue. It causes lymphocytosis, and by lymphocytosis it increases the bulk of the lymphoid tissue, and that bulk of the lymphoid tissue compresses the respiratory tree. In addition, this pertussis toxin also increases the insulin on one side. The body requires more glucose because it has to struggle to inhale, but on the other side there is hypoglycemia. So the muscles get tired. They are not able to function adequately. Another complication is that it increases histamine sensitivity. So all the effects of histamine, and as you recall, one of the effect of histamine is bronchoconstriction. So it causes bronchoconstriction, it causes vasodilatation, it causes so many other things related to histamine, and all these things compound and act in the pathogenesis of pertussis. The suffering which you have seen in that video of that small child is the combined effect of this pertussis toxin, leading to hypoglycemia, leading to histamine sensitivity, leading to proliferation of the lymphocytes, leading to obstruction of the respiratory tree. The pertussis toxin also affects the B cells and the T cells in that when the cells leave the lymphatics, they are not able to come back to the lymph node and pass on their information. The main job of wandering B cells and T cells is to capture information like the police informers, pick up the molecules which have come out from the bacteria, pick them up, analyze them, and bring that information to the lymph node and train the other lymphocytes in taking appropriate action. That is the part of the immune system. But these B cells and T cells somehow lose their way. They do not come back to the lymph node to give that information. So there is lack of information, and therefore the immune system is not able to take action as promptly as it should. It results in alteration of both antibody mediated immune system as well as cell mediated immunity, and this predisposes the person to secondary infections of the lung, which can lead to pneumonia, or even infection of the ear can cause otitis media. So what we have seen up till now is that the Bordetella pertussis bacteria, by producing its one simple toxin, pertussis toxin, can influence immune system, can predispose us to secondary infections, and can cause a respiratory tract malfunctioning. We have understood all this because we could pick up the gene which stimulates the body to produce pertussis toxin. And this gene has been cloned and expressed in E. coli. And from there, we have got the pure pertussis toxin molecule, and then we have analyzed its effect and its influence. But this also helped us into converting this toxin into a toxoid. So we are not dependent on Bordetella pertussis for getting toxin, but we are dependent on E. which are genetically modified, which produce large amount of toxin, and that toxin is then treated to convert it into toxide, and that toxide is added into the vaccine. Now, the person who gets this vaccine will have antibodies against the pertussis toxin, and therefore will be protected from all the side effects of this or all the effects of this pertussis toxin. That is the principle of component vaccines. We'll talk about component vaccine in tomorrow's class. If you remember, the cholera toxin, as we had taught to you in the third semester, the pertussis toxin and cholera toxin are quite similar, and they interfere with the regulation of the eukaryotic cell in more or less same fashion. So that was one toxin. The other toxin is adenylate cyclase toxin. This is an invasive toxin. Interestingly, the bacteria produces this toxin, but this toxin by itself is inactive. To convert it into an active form, host cell commodine is very, very important. So this activation occurs because of host cell calmodulin, and once this is activated, then impairs the immune effector cells. So somehow human body also plays an important role in making this inactive toxin into an active toxin. If you remember your first semester classes, when we talked about Bacillus anthracis, that time we had mentioned that Bacillus anthracis also produces toxins which by themselves are ineffective, but they are comodulin dependent, and because of their interaction with comodulin, they become active. Similar is the case with adenylate cyclase toxin. It's a single polypeptide. In culture medium, it leads to hemolysis of the bacteria, hemolysis of the agar. So as we've seen, it's active only in presence of eukaryotic regulatory molecule, and this reduces phagocytosis. So this particular toxin subverts our own chemical pathway and inhibits phagocytosis. घर का भेदी लंका ढाए. The third important toxin is a tracheal cytotoxin. It's simpler to understand. It's not a protein. It's a classical bacterial exotoxin. It's secreted out of the cell. It's a peptidoglycan, and what it does is it kills the ciliated cells. The ciliated cells are predominantly present in the trachea. So what happens is the ciliated cells which are lining the trachea are destroyed by tracheal toxin. Now a dead cell cannot remain in its position. So what happens? That dead cell falls off into the tracheal cavity. This also stimulates interleukin 1, and interleukin 1 is related to causing fever. So the inflammatory cycle is activated because of tracheal cytotoxin, and so the systemic effects of inflammation are as a result of stimulation of cytokine IL-1 and other factors which lead to fever and other clinical features of pertussis. Now here in this diagram you can see a bronchiole. This is the lining of the bronchiole, and the plug which you see inside are actually all the dead cells which have come out from the lining, epithelial lining of this bronchiole. So all the ciliated cells and all the other cells which die because of the effect of the toxins drop down and they form a plug. At the same time, there is inflammation stimulation. So there is macrophages, there is polymorphonuclear cells, there are other cells which also add on to this particular plug. And this plug is a sticky plug. it sticks into the respiratory tree and it does not allow the air to pass in or out. Now imagine millions of such small plugs are there all over the respiratory tree, which is not allowing the air to come. That is what we have seen that small child was struggling to. If you see that video in which the way the child is trying to take an inspiration, but he is not able to inspire or inhale the air, and the pathology is because of these bronchoalveolar plugs. These plugs will not allow the air to go. Since the air cannot cross beyond, it cannot go into the alveoli and it cannot exchange gases over there, and the person becomes hypoxic, hypercapnic. This is why this particular child is looking so ill. You can see he's trying to inhale, but the air is not coming in. In an attempt to inhale, he is exerting more and more of his inspiratory muscles, but despite that, the air is not entering into his alveoli. As we discussed earlier, there is a lethal toxin which is also known as dermonecrotic toxin because it causes local necrosis of the skin wherever it is touched upon. We really do not know its role in pertussis or in whooping cough. Perhaps the way it acts on the skin epithelial cells, maybe it must be acting on the same way on the respiratory epithelial cells and causing problem. So we've seen various toxins. We have seen how the bacteria get adhered to the cilia, how it neutralizes cilia, how it causes histamine release, hypersensitivity to histamine, how it causes release of insulin leading to hypoxia, how it prevents phagocytosis, how it stimulates the inflammatory mechanism, IL-1, etc., and leads to fever, and all that leads to the clinical feature which we call as a whooping cough. The technical name is pertussis. The name whooping cough comes because of the sound which the child makes or the person makes at the end of the cough. That sound is because the child is trying to inhale. I'll demonstrate you something. This is a narrow, long respiratory tree. After a bout of cough, the child is trying to inhale through this long tube, and this tube is blocked because of lymphoid tissue around it, because of the plugs inside, and so this is the kind of noise the child makes. And that is why it is called as a whooping cough. Now I'll ask you at the end of the class to go back and listen to that particular video and try to concentrate on this whoop which comes at the end of the cough. This is an old disease. It must have been there before 16th century also, but it was first understood and described, and it has been leading to huge amount of fatality amongst the children before the vaccination started. But after the vaccination, we are much better. So pathogenesis, summing up, addition, toxin production, damage to the cilia, antiphagocytosis, T-cell inactivation, reduce innate immunity, reduce adaptive immunity, peritracheal, peribronchial lymphoid hyperplasia, leading to pressing on the lymphoid, pressing on the channels, necrosis, desquamation of the epithelium, causing plugging, macrophage infiltration, histamine, serotonin, insulin imbalance, and all this adds to what we call as the pertussis. The bacteria enters through the respiratory tract. It produces disease by affecting the brain, encephalopathy, causing nose, rhinorrhea. Most important, it causes paroxysm of cough because of involvement of the trachea, bronchi, bronchioles. It can lead to pneumonia. It can lead to secondary bacterial infection, or it can get into the systemic circulation and can cause lymphocytosis and other features. And then the bacteria again gets out through the oral cavity and spreads to another person. The clinical feature of pertussis is very, very long. The incubation period itself may be as short as 4 days if large number of bacteria are inhaled, or if small number of bacteria inhaled, then up to 21 days till the bacteria multiply, produce enough toxin and can cause problems. So we can have very long incubation period. And the stages are 3 stages. Catarrhal stage, where primary involvement of the nose and throat. Paroxysmal stage, where there is primary involvement of the lungs. And a convalescent stage, where the recovery of the patient occurs. And all these phases are also quite long. Almost 1 to 2 weeks of catarrhal stage, as long as 6 weeks of the paroxysmal. Imagine some child coughing for 6 weeks like that. It will exhaust him, it will deplete his nutrition, and that's what leads to secondary infection as well as deaths. And then even the recovery takes months. So during this recovery phase also, the child is not able to develop, grow, and does not attain his developmental levels or developmental milestones and remains behind in everything. So here is a small diagrammatic representation. Small catarrhal stage, long paroxysmal stage, and very long convalescent stage. Let's have it over here. Catarrhal stage may start after getting infection and will continue up to maybe sometimes up to 2 weeks, sometimes up to 3 weeks. And during this period, the person is having beginning of the cough, but there is a lot of rhinorrhea occurring. And this is the time when large number of bacteria are being spread out. So first 2 or 3 weeks of the paroxysmal stage and the last 1 or 2 weeks of the incubation period are the ones where the bacteria are spreading out of the patient. And diagnosis during this stage is not so easy. And that is the reason that we may take it as, oh, it's a common cold, it's just a mild cough. And that is the time when the child is going to school or is playing with his friends and transmitting the bacteria to everybody. After that comes the paroxysmal stage. Paroxysmal stage is called so because of the paroxysms of cough. Paroxysm of cough means the patient starts coughing till all the air is expelled from the lungs, and then there is a big inhalation. So why does the patient cough so long? Is because he is trying to throw out all the secretions which are blocking the respiratory tree. And to cough, what we need to do is we need to expel the air. How much air can you expel? Only as much as is in the lungs. But despite trying to expel all that, the particulate matter, the plugs do not get out of the bronchial tree because they are stuck, they are attached. They just keep on moving up and down, up and down. And at the end of it, the patient has lost all the air from the lungs. He is no more able to cough out. This is time for him to inhale. And when he inhales, there is air hunger and the tubes are narrowed. So the noise of the whoop comes when the child inhales. These are called as the paroxysmal stage. During this stage, the person is not to swallow because every time there is a swallowing or eating, it leads to a cough. And Cough does not allow him to do anything else. Beyond that comes the convalescent stage. After about 6 weeks of this severe coughing, by the time patient has lost a lot of weight, lot of energy, lots of proteins, lots of calories, and then convalescent stage where gradual recovery occurs. So these three features of catarrhal stage are common like any other upper respiratory tract infection and do not differentiate between one respiratory tract infection to another. This is the acute phase, which is the most severe. It leads to the fits of cough. Cough is dry and harsh. No sputum comes out of it, and the cough is followed by a whoop of the inspiration. Now, during this coughing, because there is contraction of the diaphragm also, and there is contraction of the stomach, the person may vomit also. This vomiting sometimes will get aspirated and can cause further problem. The cough can start with any stimulus. A small breath of cold air can stimulate. A drop of food can stimulate. Milk can stimulate. Anything going into the upper respiratory tract, touching the pharynx, can stimulate a spate of cough. And therefore, the patient avoids eating and drinking, may go into dehydration, may go into negative caloric balance, protein malnutrition, and will suffer further infections. Along 4th week or 5th week of this incessant cough, the child cannot sleep, the child cannot eat, the child cannot drink. Nobody in the house can sleep because the cough is so severe. Around after 4 weeks of such, the first thing to start is that the patient stops vomiting. So if mother comes to you with the complaint that child has been coughing since last 1 or 2 weeks, and then after 1 week or so the mother comes and says that child has not vomited today, be happy that now child has gone into a recovery phase. So stopping vomiting is a very important indication that patient of whooping cough is on the recovery phase. Around 6th week, the intensity of the cough may decrease. Child may start accepting feeds, child may start accepting milk, child may start accepting more and more food, may get more and more hungry, but episodes of cough can continue for another 2-3 weeks or even a couple of months. And during this period, because the tracheal epithelial lining is damaged, there are no more cilia, many other bacteria from the oral cavity can enter into the lungs and lead to pneumonia. So Staphylococcus, Streptococcus, Haemophilus, all other bacteria can add on and cause pneumonia, and the child may recover from whooping cough but may die of pneumonia. What are the major complications which can occur? The complications occur primarily because of the inability to breathe. So all complications are associated with hypoxia. Hypoxia of brain, hypoxia of liver, hypoxia of kidney, hypoxia of heart muscles, hypoxia of gastrointestinal tract, everywhere. The child, because the moment child tries to breathe in, it initiates a cough. So child may hold breath, may go into apnea. In an attempt to stop coughing, the child may hold breath. So there could be apnea, which complicates hypoxia. We already talked about pneumonia. Hypoxia of brain can lead to seizures. Also, because of incessant coughing and the depth of coughing and the force of coughing, there is rupture of the microcapillaries. There is rupture of the capillaries and other microvasculature, which itself also can lead to encephalopathy or seizures if it occurs in the brain. The Toxins also can lead to encephalopathy. So patient may have seizures, may have encephalopathy, may have pneumonia, and because the child is not able to eat but is consuming lots of energy, he goes into protein calorie malnutrition. Many children who are unvaccinated die. And many children who cannot be vaccinated because they are too young may suffer from pertussis and die. Now that brings us to the thought, why don't we vaccinate the children right at birth so that they do not suffer from pertussis? Unfortunately, that is not yet possible. Why it is not possible, we'll see when we'll talk about the vaccines. Maybe you can read a little bit about vaccines before you come for the next class so that you can understand why we cannot vaccinate children at birth and prevent this particular dreaded complication. Look at this child, poor child. He is not able to breathe. Look at the anxiety in his eyes. Look at the cheeks. Look at the fear which you can see on his face. I am not able to breathe. What is going to happen to me? Look at the nose. It is blocked already with the secretion. It's flaring because it is trying to take the breath in, but it is still not able to take a breath in. Look at the effort the child is making. This is tremendous, tremendous suffering for any child. If you have seen a case of pertussis, you'll be devastated just by looking at it. As I was mentioning, because of the effort of the cuff, there could be breakage in the capillaries, and patient may come with conjunctival hemorrhages. And since this is only manifested, we can see the hemorrhages over here. But similar breakage of the capillaries can occur in the brain and can lead to changes like encephalitis. It leads to severe headache because of these micro hemorrhages in the brain. So how do we diagnose and how do we treat? We'll be talking about it in greater detail in the next class, but just to sum up quickly, the diagnosis is primarily on clinical suspicion, just like in diphtheria. For the simple reason, the isolation of the organism takes a lot of time. It's a slow growing bacteria. Secondly, it requires specialized media, which is not available at most of the places. This disease is common amongst the poorer, overcrowded population, which do not have access to healthcare facilities. And if you wait to diagnose when the actual whoop occurs, perhaps it is too late. So you have to have a clinical suspicion that if in a locality some other children are having this disease, any other child who develops catarrhal symptoms should start thinking it could be a person having pertussis. When the characteristic paroxysmal cough develops, when the whoop develops, anyone can diagnose. It is no brainer. You don't have to be a doctor to diagnose that. It's also called as kali khasi or ghoda khasi because of the amount of paroxysm it causes. But if the child comes with a history, there is a cough which has been persisting for more than 2 weeks, and there is a vomiting at the end of the cough, your diagnosis is more or less sure. If there have been more cases in the community, you're almost 100% sure. But to diagnose it in the laboratory, you need to collect the specimen very early during early part of the disease manifestation. And the specimen is same that we collect for COVID, that is nasopharyngeal swab. You pass the swab parallel to the nose, not up, but parallel to the palate. So it goes into the pharynx, it rubs up over there at the posterior nasopharyngeal part and take out the swab and then it transport in 1% acid hydrolyzed casein. This is important because the bacteria are fragile. Bacteria are fastidious. They may die during transport. We also take Ami's charcoal medium for transporting because charcoal will neutralize the fatty acids which can kill the bacteria. So this is one of the ways by which you can obtain the swab and send it to the laboratory. Not a very efficient method because recovery of the bacteria is not so well from the swab for obvious reasons. So a better method is a cuff plate method. In the cuff plate method, consider this to be a petri dish, bordered Genju medium or charcoal medium, and then when the patient is coughing, this plate is brought in front of the patient so that while coughing, all the respiratory secretions are cuffed onto the agar surface of the plate, and that is inoculating the agar directly by the respiratory efforts of the patient themselves. So during the cough paroxysm, keep the plate over here, let the child cough, cow, 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 cow onto the plate, cover it, and send it to the laboratory. But for that, you need to have the plate. That means you have to have a laboratory next to it. So again, not very much possible in our country. So therefore, in our country, even now, to a great extent, the diagnosis depends on clinical presentation and it is late diagnosis. So to suspect early diagnosis, you need to ask one important question to the mother or the father of the child. What is that question? What question should you ask when you get a patient who is coughing and when you think that patient might have whooping cough? What question should you ask? Any guess? Anyone? One intelligent question which can decide whether patient is having whooping cough or something else. Whether there is a possibility of whooping cough or there is no possibility of whooping cough. What question should you ask? Anyone? Anyone would like to answer? I'll wait for
So
you.
having
Yes?
uh, so just a guess, if the patient is having breathing problem or kind of
You don't have to ask the patient if he has got a breathing problem because you can see that right in front of you. Some other question. Daiti?
so can't think of it.
Think. It's a very common sense question. If I tell you the answer, you'll say, oh my God, why didn't I think about it? One simple question to the mother or the father whosoever brings the child, and that can decide whether patient can have pertussis or no pertussis. One simple question.
So
So about
vaccination.
the
Yes, someone is saying something in the background.
So vaccination.
Ask the question. I am suppose the father of a patient. What question would you like to ask me?
so about
Yes.
the nature of the cough, like
Is child
sound
willing?
Again, someone can ask me that question.
Is the child willing to eat or not? Is he vomiting?
Yeah, he's vomiting. But any other question? Someone was saying something.
so
Someone was, yeah.
so we can ask about the cough, the sound that is being produced like while
You,
coughing.
you, you don't really have to ask. If the patient is sitting in front of you for 1 minute, he will make the sound. But one question, yes.
Uh,
Yes, someone. Let's see. Someone was asking that question while stopped in between.
So did your child get the routine pertussis vaccination?
Absolutely right. Absolutely right. So there you are. Okay. Who was that?
Pratishma.
Okay, Pratishma. So there is your toffee lying with me. Okay. Claim it when you come back. Yes.
Thank you, sir.
One most important question which you need to ask every child which comes to you is which all vaccines the child has taken. If they can have the record, That is the best thing. But many of the children will not have record, will not have any paper proof that they have taken vaccine. So how can you ask that question is, how many times which vaccines have been given? The child will or the father will definitely remember or the mother will remember how many injections the child was given and when all were given. And if you have the idea as to what is the schedule of vaccination in our country, you can make a guess. Okay, if the child was so many 6 months age, was he given an injection? Okay, so it could be one. Was the child was given another injection after some time? Yes, the second dose of the same one. Was child given some drops subsequently? Yes. What it could be? It could be polio drops. So you need to know the vaccination schedule which is applicable in your country, the route of giving the vaccine also, and which vaccine is given by that particular route. If you ask this intelligent question, that's what is Sherlock Holmes. Sherlock Holmes asks intelligent questions and gets the answers and then analyzes those answers. That's what you need to be. So simple question, when all vaccines were given and how they were given, were they given as injection, were they given as drops, were they given in the thighs, were they given in the arm, did it lead to a scar, did it lead to a fever in the child, did it lead to any local changes? All these interesting questions can give you an answer whether the child was vaccinated or not. If the child was not adequately vaccinated for pertussis, think of pertussis because you can save the life. If the child gives a definite history of having vaccinated for pertussis, please reconsider your diagnosis. You might be missing something more important, more severe than pertussis. Okay? So that question needs to be asked. And once you ask the question, if you still think it is pertussis, collect a nasopharyngeal swab, or if the cuff plate method is possible, collect the specimen like that and send it through the laboratory. But laboratory is not going to give you a reply within 24 to 48 hours. The organisms are slow growing. They'll grow like this. Dome-shaped mercury silver colored organism on RL medium because of the black charcoal, and they'll shiny. If it is a blood agar, they'll show hemolytic colonies. But this is not a very sensitive method. It does not grow so easily because from here there will be, if it is a cuff plate method, there will be thousands of other type of bacteria. We'll have to pick up some colony, stain it, see it is that cocobacillary form, small in size, then subculture it, then make a pure growth, then perform its serotyping. There is no biochemical reaction except catalase test, then perform serotyping and then identify and tell you it is Bordetella pertussis. By that time you'll say, I have already diagnosed, my patient is already dead. Very sad. So laboratory diagnosis does not play much role in acute management, but it can give you an indication as to what is happening in the community and that can help you in treatment of the patient. Why not go for PCR? Well, unfortunately, so far PCR has not been standardized for diagnosis of pertussis. Why? Is it so difficult? No. Why is it not been diagnosed? Why it has not been standardized? Is because most of the PCR standardization is done in developed countries. And pertussis is not a problem of developed countries. So why should they waste their efforts, energy, resources on this? Who are required to do it? We are required to do it. We in the developing countries need to make PCR protocols for identification of pertussis at the earliest. Nowadays, PCR is available at most of the laboratories. So we should be able to devise these protocols and then we can give a diagnosis within 6 to 8 hours. Another way is we can do a fluorescent antibody testing. That means take the patient's cuff, cover it with the antibodies which are fluorescent tagged and try to see whether you can see the antigen-antibody reaction over there demonstrated by fluorescence. Not a very efficient method because there will be lot many other organisms also present which also can give cross reactions. So another, it could be by ELISA, estimate the antibodies. But antibodies will form only after about 14 days. By that time, the child will be suffering. And antibodies could be having cross reaction with influenza, mycoplasma, so many other things. Not a very sensitive method. So what we need to do is, we need to devise PCRs, which can be useful in periphery also. Maybe this is a challenge to your batch of students. Maybe someone amongst you can pick up this particular method, do a PCR standardization, and then you can diagnose pertussis much more easily in our situation. Why it has not been done so far is because prevention of pertussis is easier and cheaper as compared to diagnosis of pertussis by PCR. So we have not yet tried, but it can be tried because there is some group of patients who before vaccination will suffer from this and may need this particular diagnostic method. So how do you treat the patient? Well, antibiotics play a very important role because we need to kill the bacteria so that further production of toxins and other virulence factors is reduced. So azithromycin or erythromycin antibiotic treatment is indicated because the bacteria are quite sensitive to that. But more important than that is the supportive care. Supportive care for the cough, supportive care for the oxygenation, supportive care for the nutrition, supportive care to prevent aspiration pneumonia, to prevent secondary bacterial infections, to make sure that the child gets sleep, make sure that child gets rest, make sure that the child does not undergo malnutrition. So those supportive treatments are very important besides the antibiotic therapy. So there we'll stop, and in the next class we'll talk about pertussis vaccines. I again request all of you to go and have a look at that particular video, see it 10 times, get the feel as to how the child is suffering, and ignore the two girls who laugh at the end of the video. Never do that. Never do that when your patient is suffering. It shows callousness. Be sympathetic to your patient. So any questions, any doubts up till now? I guess we have overshot today by a few minutes. So maybe we can take these questions in the subsequent class. We'll have some time in the next class. So tomorrow we'll talk about vaccines. I suggest you to go through the pathogenesis of the disease, go through the video. Maybe if you can give a gentle reading to the vaccines about pertussis and the problems which we face in vaccination, then you will be in a better position to understand what we are going to talk tomorrow. If you still have any questions, feel free to put them on your chat, or maybe you can ask them tomorrow or any other time also. So any doubts, any questions up till now? Anyone having any doubts? Would you like to ask them right now? You can. If there are no doubts, then maybe we can stop today and we'll continue from here tomorrow. Thank you very much. Take care, stay safe, enjoy the classes, learn a lot, and be a sympathetic and competent doctor. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir.